My name is Vicki Rossetti, and I want to welcome everyone to class. I want to thank Respiratory Associates for the service that they provide to respiratory therapy with continuing education, and for this opportunity for me to share with you. Take a deep breath in. Spirometry is the most common pulmonary function test, and it is widely used in the assessment of lung function to provide objective information used in the diagnosis of lung diseases and monitoring of lung health. Today, we are going to use 4 maximums to coach bedside spirometry to meet ATS ERS criteria for acceptability, usability, and repeatability. And this is approved for 1 CRCE with the AARC. Again, my name is Vicki Rossetti. I'm a respiratory therapist currently working in pulmonary diagnostics, and I have no conflicts of interest to report. All right, so let's get started. Learning objectives. At the conclusion of this presentation, the learner should be able to describe the basics of spirometry context, explain 4 maximums within the forced vital capacity maneuver, and explain troubleshooting and coaching to correct spirometry errors and meet ATS ERS criteria. Let's get started with the basics. We'll talk about definitions, volumes, capacities, and levels, and operator factors. So spirometry is a physiological test that measures the maximal volume of air that an individual can inspire and expire with maximal effort. The most relevant measurements: how fast can you breathe, measured by the FEV1, the forced expiratory volume in the first second of an FVC maneuver. How much can you breathe is the forced vital capacity, FVC. And that's the maximum volume delivered during an expiration made as forcefully and completely as possible, starting from full inspiration. Acronyms. The American Thoracic Society is the United States entity that governs and develops the guidelines for spirometry. The European Respiratory Society for Europe, and in 2019, the ATS and ERS jointly published the most recent version of spirometry guidelines. The operator is the person conducting the tests, and that is our target audience for today's class. Patient is the person being tested. They could be a patient, or they could be a biological quality control. They could be someone learning or teaching spirometry. The maneuver is the term that is used for the inspiratory and expiratory vital capacity excursion. Must is used to indicate a requirement, and should is used to indicate best practice. The heart and soul of spirometry, of course, is the spirogram. Spiro is the combining form referring to respiration. A spirograph or a spirogram is the tracing of the ebb and flow of respiration in and out of the body. Respiratory therapists are very accustomed to tidal volumes that we talk about with mechanical ventilation. This is basically the same thing. Starting from the resting point, this resting point is the most reproducible point on the spirogram. And it's reproducible because at this point, there's no inspiratory effort, there's no expiratory effort. There's simply the equal and opposite components of the lungs trying to recoil down into collapsing, getting smaller. And opposed to that is the recoil of the chest wall, with the rib cage wanting to spring open and get bigger. So the lung recoil versus the rib cage recoil are the only forces, in fact, and at the resting point, they are equal and opposite, which makes this resting expiration our most reproducible point on the spirogram. All right, volumes. There are 4 volumes. Let's start with the most well-known, tidal volume, in and out, typically 500 mLs by textbook value. What you can breathe in after a resting inspiration, that maximal inspiratory effort, all the way up to a maximal inspiratory line, is known as the IRV, or the inspiratory reserve volume. What you can breathe out from the resting point is the expiratory reserve volume. What you can breathe out after you have exhaled a normal resting tidal volume. The amount of volume that remains in the lung after you've done a maximal expiration is the residual volume, or RV. So 4 volumes, tidal volume, what comes in and out for restful breathing. Inspiratory reserve volume, what you can breathe in after you've already inhaled a resting tidal volume. Expiratory reserve volume, the ERV, what you can exhale after exhaling a tidal volume. And residual volume, what remains in the lung after that maximal expiration. You combine any 2 or more volumes and you end up with capacities. We have 4 capacities. Combine the inspiratory tidal volume with the maximal inspiratory reserve volume and you get the inspiratory capacity, or IC. You combine the expiratory, maximal expiratory, you combine the ERV with the RV, what's in your lung at the end of a resting exhalation, and you get the functional residual capacity, or FRC. The maximum volume of air that can be moved from a completely inspired, totally full lung, the maximal inspiration, all the way down to the maximum expiration is the combination of the IRV, the TV, and the ERV. And that gives us the vital capacity, or the VC, which is the heart and soul of spirometry. We'll talk many times about the forced vital capacity. We'll also talk about inspiratory vital capacities. And of course, you add all 4 of the volumes and you get the total lung capacity, which is the maximum amount of air that can be in the lungs at the maximal inspiration. So we're going to also identify 4 levels for the purpose of communication here. We've got the maximal inspiratory level, which is where you are when you have inhaled as much as you possibly can. This is going to be referred to today as the TLC, or total lung capacity level. We're going to talk about this resting expiratory level using the term FRC level. We're going to talk about the maximum expiratory level, which is where you are after you've done a maximal effort to breathe out everything you can, and we'll refer to that as RV level. And of course, once again, FRC level is the most reproducible point on the spirogram. All right, there are 3 key elements to obtain high quality pulmonary function data: accurate and precise instrumentation, not today's subject; a patient or subject capable of performing acceptable and repeatable measurements; and a motivated operator or technologist to elicit the maximum performance from the patient. And today's topic is about the patient and the operator working together to use 4 maximums to get their ATS requirements. The importance of the operator was a key message derived from a patient experience survey. Many patients emphasized that it made a real difference how friendly and encouraging the operator was. Some felt that the operator needed to fulfill the role of a cheerleader and that it made a difference to their results. Patients also felt that before, during, and after, the operator needs to have empathy, that it's important to check on the patient, see if they're ready and how they feel about performing the next maneuver. Patients also felt that it was important that the operators did not express disappointment when the patients have trouble completing the test. And though many felt that the encouragement or coaching is very important, some patients would rather have preferred a gentler approach rather than shouting instructions to blow. It is the responsibility of the operator to observe and engage with the patient to achieve optimal results, which requires a combination of training and experience, hence today's continuing education. All right, we're going to talk about 4 maximums within the forced vital capacity maneuver. As part of the spirometry procedure, we're going to talk about 4 maximums as within maneuver criteria for acceptability and usability. We're going to talk about 4 maximums between maneuver criteria for repeatability. And we're going to talk about 4 maximums as session quality grading. So let's get started. What are these 4 maximums? All right, this is our spirogram, having the patient breathe out, breathe in, normal tidal volumes. Then we instruct them to take a deep breath in blast it all out, keep blowing out, take another deep breath in. So we begin with the normal tidal volume. Inspire rapidly until completely full, and this gets us to our first maximum, the TLC, total lung capacity. Then expire with maximal effort, gets us our blast of expiration, maximum number 2, from which we measure the FEV1. Continue to expire until completely empty, continue up to a maximum of 15 seconds, brings us to our maximum number 3, end of forced expiration. Old term, end of test, no longer applies. And from the end of forced expiration, or EOFE, we get our forced vital capacity. Then we tell the patient inspired with maximal effort until completely full for our fourth maximum, which is the inspiration, the forced inspiratory vital capacity. For optimum quality control, the operator displays and inspects both volume time and flow volume graphs for the 4 maneuvers after each forced vital capacity maneuver. Operators must evaluate the 4 maximums in the tracings of each FVC maneuver to determine if they are acceptable and/or usable before proceeding. The patient is to be coached to correct errors on the next FVC maneuver attempt. Volume time graphs come in 2 versions. On the left, you see a multi-breath volume on the y-axis and time on the x-axis graph. These are best utilized to see the full spirogram, including the tidal breathing and the complete forced vital capacity maneuver. On the right, you see a single breath, volume on the y-axis and time on the x-axis graph. These are best utilized to see only one FVC maneuver and are the best way to evaluate the third maximum, end of forced expiration, from which we get the forced vital capacity. So the 4 maximums on these volume time graphs are right here. Number 1, TLC, when the breath is completely full, and this is your TLC on the single breath. Max, the blast out to get us our FEV1, is the early part of this, and up to here you can see 1 second on the FEV1 has been marched out here in dashed lines. The max number 3, end of forced expiration, from which we get our vital capacity, is here, and the 4th one does not show on these graphs. The flow on the y-axis versus volume on the x-axis graph is the best way to evaluate the first second of the FVC maneuver. The expiratory flow is plotted upward, and the expiratory volume is plotted to the right. Inspiratory flow is plotted downward, and inspiratory volume is plotted to the right. The flow volume graph is useful to assess the magnitude of effort during the initial portions of the maneuver. Because this portion of the maneuver, particularly the peak expiratory flow rate, which you see up here at the peak, is correlated with the pleural pressure during the maneuver. The ability to overlay a series of flow volume graphs may be very helpful in detecting sub-maximal efforts to be discarded and for evaluating repeatability. The 4 maximums on the flow volume loop are right here, starting at the base. That's when the patient is totally full. The max number 2, FEV1, is at a spike on the graph partway down. The max number 3 is when it completely comes back to the x-axis. And graph number 4 is back up to the TLC. All right, now we're going to look at the 4 maximums with the forced vital capacity as part of the spirometry procedure. According to the 2019 guidelines from ATS and ERS, there are 3 components to the spirometry procedure. The first one is to prepare the patient. The second one is to instruct and demonstrate. And the third one is to coach. Now, they prefer, ATS ERS prefers inspiratory and expiratory devices that measure both directions, But in home care, in physician offices, in screening, public screening, there's a lot of expiration only devices. So we will just mention them briefly in passing. All right. The height must be measured without shoes, with the feet together, standing as tall as possible with the eyes level and looking straight ahead, and the back flush against the wall or stadiometer. For patients unable to stand, height may be estimated using an arm span or an ulnar length, which should be measured in calipers. Okay. Take a note that the arm span is actually a two-person job. You want to make sure that the tape measure does not get curved around the patient's back or front. So you put the tape measure against the wall, and you have one person measuring over here at the end of the longest finger, and also here you want to make sure that the elbows are as straight as the patient is able to do. Okay. Height needs to be measured in centimeters into 1 decimal place, or can be measured in inches. Don't use the height the patient tells you or the height on their driver's license. True story. A patient came to me for a pulmonary function test. The indication for the test was a previous test, which was highly unusual and made me very suspicious. But I decided not to prejudge by looking at the previous tests. I went in, I completed his pulmonary function test, and then I pulled up the old test. And I'm looking through, and all of the absolute values are essentially identical. And I'm like, why did they come and get another test? Then it dawned on me. The percent predicted was very different, significantly different. Now, this person was trying to get into an occupation that they wanted to work in. And military, first responders, and some other types of occupations require that the patient document that they're not going to have any particular respiratory problems, particularly if there's any history of asthma or other respiratory issues in their medical history. So they have to come and do this. Now, the people reading these tests are only looking for a value, that's the percent predicted, to be above or below a given point. So that's decided by the occupation or the employer. And this person had the outcomes, the percent predicted were below that value. And I realized that when I saw that the percent predicted were so different, I asked him, did they measure your height? And he said, no, they used the height on my driver's license. Well, many males are taller on their driver's license than they are on my stadiometer. Many females have a lower weight on their driver's license than on my scale. So just be very careful. Make sure that the height is very, very accurate. It is critical. Weight, not so much. The predicteds are based on height, gender, age, and race. So it's important to get those correct. All right. Sitting awkwardly, twisted, slumping are not conducive to achieving good results. The patient should be seated erect with both feet flat on the floor, shoulders slightly back, chin slightly elevated. I like to tell the patient, sit as tall as you can. Sit tall, stay tall. The chair should have arms to prevent falling sideways if there should be syncope, which does occur. The chair should not have wheels and should have a height adjustment so that the feet can be nice and flat on the floor for good support. Handheld spirometers, the flow tube should be level to the floor. If testing is undertaken with the patient in another position, this must be documented in the report. Tests done while standing are similar to sitting in studies of adults, obesity, and children. Fowler's sitting on the side of the bed, Fowler's position, head up and head and torso up, they yield higher values than supine or Crook's position. In most studies involving healthy patients with heart, lung, and neuromuscular disease. However, for subjects with tetraplegic spinal cord injuries, the FVC and FEV1 were higher in supine than they were in sitting. So that any position other than sitting needs to be documented in the comments. All right, our 4 maximums in our instruct and demonstrate. The new standards focus on the use of devices that measure both expiration and inspiration with these 4 distinct phases. Big breath in, fast, all the way to completely full lung. This brings us to our maximum number 1, the inspiration to total lung capacity. Blast out hard and fast, use all the force available. This gives us our maximum number 2, blast out, from which we get our FEV1. Keep blowing, keep blowing, keep blowing out all your air. This brings us to our maximal number 3, end of forced exhalation, from which we get our forced vital capacity. Big breath in fast, all the way to completely full lung, gets us to our 4th maximum, the FIVC, forced inspiratory vital capacity. After you prepare the patient and instruct and demonstrate, then you want to coach as the patient does the maneuver. Quick synopsis: sit tall, stay tall, mouthpiece and nose clip, normal breathing, deep breath in, more, blast hard. Keep breathing out, 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 deep breath back in. All right, a little more detail. Dentures are best left in place because they provide essential support to cheeks and lips. However, if they fit poorly and obstruct the airflow in any way during the maneuver, it is better to remove them from the mouth. The mouthpiece used in the spirometric testing may vary from instrument to instrument. It is essential that the patient puts the mouthpiece in between the teeth with the lips around it so that the air can pass freely and the mouthpiece is sealed firmly by the lips. A nose clip is not mandatory for forced expiratory maneuvers. Some patients prefer to hold their nose with their fingers. However, occasionally subjects blow out or inhale through the nose so that it is safer to always apply a nose clip. If the nose clips won't stay put on their nose, try an alcohol wipe for their nose. Position of the mouthpiece and nose clip need to be very carefully done to avoid leaks. Patients that are unable to use a mouthpiece may be able to use a face mask. In some circumstances, such as patients with trachs or nasal resections, non-invasive adjustments such as sealing the face mask, variety of tubing connections or occlusion valves can be applied at the discretion of the operator and must be in the operator notes. All right, so we're going to tell the patient normal breathing, breathe normal, resting, easy breathing. Nice tidal breathing. You're going to use the volume time graph of multi-breaths to watch for similar size and shape tidal volumes evenly spaced. Clear out the inconsistent breaths, particularly when they're first learning to breathe through the machine and getting to be at rest with that. Look for that nice, steady baseline stability, at least 3, preferably closer to 5 tidal breaths with end expiratory lung volumes within about 15% of that volume. You want to watch the flow volume loop for overlying tidal breaths. Are they moving to the right or are they moving to the left? They could be leaking. They could be stacking. The expiratory flow limitation, COPD patients, asthma patients, they might be inhaling more and exhaling less, inhaling more, exhaling less, and they could have some of their air being stacked up. And so you want to be aware that if their tidal volumes are moving toward the left as they do their breathing, that they are stacking, and you want to not have them do that. You can coach them to breathe more out. Take note that patients with very high BMIs may move their tidal volumes down here where there's very little ERV, and patients with lower BMIs may be more centric to your flow volume loop. All right, maximum inspiration. Patients should be informed that the maximal inflation is not natural. They may not have achieved it before, and it may seem somewhat uncomfortable. Reductions in peak flow and FEV1 have been shown when inspiration is either slow or there is a 4 to 6 second pause at the TLC before beginning that blast of expiration. It is important, therefore, that the preceding inspiration be rapid and any pause at full inspiration be minimal, less than 2 seconds. The operator should be in a position to view both the patient and the display on the testing device. But the major sign of the subject having achieved a full inflation will come from the patient. The patient's head and face should be observed while the command to inspire as deep as possible, not just take a deep breath, is given. During the inspiration, the operator should coach the patient using phrases such as more, more, more. Indications of maximal inspiration include eyebrows raising, eyes widening, and sometimes the head will begin to quiver or bobble. A patient who looks comfortable is not likely to be at full inflation. Max number 2, blast hard. Not just blow, but they have to give a maximal effort, a hard, fast, maximal effort. They have to be sitting upright. Don't allow them to lean forward or put their chin down. While they're blasting, you want to look for a nice sharp peak up here. You want that sharp peak to be very close to the y-axis, not leaning over to the right. And a rounded peak is a sub-maximal effort that should be discarded, but never discard the first blow. For plenty of patients, the first blow is the best you're going to get. Never discard that first one. All right, max number 3, end of forced exhalation, from which we get our forced vital capacity. You're telling the patient, keep blowing, keep blowing, keep blowing, keep blowing, keep blowing, keep blowing. End of forced expiration has 3 definitions. First is a plateau of more than 1 second, and a plateau is defined as being less than 0.025 liters per second change. Most software will give you a visual or audible indicator that you have reached a plateau. Once you have reached it, you need to maintain that plateau for more than 1 second before you terminate and have them go back to the FIVC. If you never get to a plateau, second criteria for end of forced exhalation is a forced expiratory time of 15 seconds or more. You do want to watch for lightheadedness and syncope. Sometimes patients cannot really tolerate that end of forced expiration. If you never reach plateau and you can't reach 15 seconds, the FVC might still be acceptable if it is repeatable, but you've got to tell that after multiple attempts. The deal breaker is glottic closure. You cannot have the glottis closed and prematurely end the forced expiration. We do get our forced vital capacity from here. Just a nod to some of us old timers. The end of test that was from the previous guidelines is no longer an appropriate measure, and the 6 seconds or more is no longer an appropriate measure. All right, deep breath back in. This is going to the max number 4, the forced inspiratory vital capacity. Ideally, you want that FIVC to be equal to the FEVC. If your FIVC is bigger than your forced vital capacity, the most likely issue is that the patient may not have been completely full, may not have been at TLC before the blast. So you want to coach them on the next one to take more before that blast. Also very common is a leak. Patients may have leaked on the inspiration or on the expiration at the mouth or at the nose, and make sure you don't have a leak in your circuit. But leaks can also make your FEVC be less than your FIVC. If your FIVC, like you see here, is less than your FEVC, the patient needs to make sure that they breathe in fast and deep to a full lung on that FIVC, that 4th maximum. Here's our nod to the expiratory only devices. The expiratory only devices still use the same 4 maximums, but they don't breathe in through the device. So they're going to do their normal breathing and their maximal inspiratory breathing to TLC before they put the device in their mouth. Once they have inspired to TLC, then they put in the mouthpiece and blast out. And it's important that that does not take more than 2 seconds. So you have them do their normal breathing, deep breath in, put the mouthpiece in, and blast out. And only 2 seconds up there at TLC. And this is where sort of that end of test from the previous guidelines can apply, because they're not going to be taking that forced inspiratory vital capacity back in. All right. So we have explained the 4 maximums within as part of the spirometry procedure. And now we're going to go and talk about the 4 maximums as within maneuver criteria for acceptability and usability. So the ATS ERS have defined these 2 terms. Is it acceptable and is it usable? The criteria were developed as objective measures to determine whether a maximal effort was achieved, whether you have an acceptable FEV1, and whether or not you have an acceptable FVC. Sometimes you can't get acceptables, and even though you may not get an acceptable FEV1 or FVC measurements, they might still be clinically useful, hence the term usable. From the guidelines, Table 7 is a summary of acceptability, usability, and repeatability for criteria for FEV1 and FVC. So these are the acceptabilities for FEV1 and the acceptabilities for FVC, the usabilities for FEV1, and the usabilities for FVC. We'll go through these individually. Still looking at our 4 maximums within the maneuver for acceptability. The first one is TLC. The TLC does need to start from the end of the normal tidal exhalation, or you could say the resting expiratory level, or you could say the FRC level. Again, that reproducible level where the lung recoil and the rib cage recoil are equal and opposite. So you want to make sure they start from that point. They want to go up to the maximal inspiration or the TLC level, and they want to make sure they inhale the maximum volume. Okay. You can see that on your graphs. Okay, here they're doing their tidal breathing. You tell them take a deep breath in, blast it out. Keep blowing, keep blowing, keep blowing. Deep breath back in again. So your FIVC is considerably bigger than your FEVC, your expiratory vital capacity, which means that they were not full before they began. Going to the second maximum, the FEV1. Now we're looking at 2 parts here. Displays of flow versus volume provide more detail than volume time graphs for the first second of the FVC maneuver. Because this portion of the maneuver, particularly the peak expiratory flow, PEF, is correlated with the pleural pressure during the maneuver, the flow volume graph is useful to assess the magnitude of effort during the initial portions of the maneuver. The ability to overlay a series of flow volume graphs registered at the inspiration can help in detecting submaximal efforts that need to be discarded, and can also help in evaluating repeatability on a visual way. Okay, so you want to look at both the start of the FE1 blast. We're going to be talking about the time 0 calculation, the back extrapolation, and delays and leaks. Okay. Then you also want to talk about the peak of the blast, talking about both the rise, the sharp point, or the rounded submaximal. Okay. Ideally, you're going to see them taking their tidal volumes, take a deep breath in, blast it out. Okay. So we're looking at both. Here we're looking at the delayed start, a hesitation of 2 seconds, more or less. This particular graph comes down here, and it has a 0.62 seconds of time between being at TLC and starting that exhalation, that blast out. So this is an acceptable maneuver. This one was at TLC, had a hesitation of 2.21 seconds before the blast, and so that one is not an acceptable graph. Here you can see the delayed start there. You're also going to be looking at false starts or leaks. Okay, you can see them in various forms on the various graphs. You want them to be 5% or 0.1 liters, whichever is greater. This is called back extrapolated volume. The back extrapolated volume does need to be less than 5% of the forced vital capacity of that same maneuver, or 0.1 liters, whichever is greater. So here's how we calculate that. You find point on the graph, which is your peak expiratory flow, and you draw a straight line through that point at that slope back to where it encounters the x-axis, and that becomes your time zero. Okay, this is a line with a slope equal to the peak flow through the point of peak flow on the volume time curve. Okay, the back extrapolated volume is equal to the volume of gas that was exhaled before the time zero. This one, magnified right here, is acceptable. This one is not. How do you calculate it? So you pull up your calculator from your computer and you find your back extrapolated volume, put that in your computer, divide it by your peak, your forced vital from the exact same maneuver. 0.08 divided by 1.93 is 4.1%. This is less than 5%, so this back extrapolated volume is an acceptable maneuver. From the same patient in the same testing section, we have an unacceptable maneuver, okay? The 0.11 divided by the 1.87 vital capacity is 5.8%, which is bigger than 5%. So this is an unacceptable maneuver. You would discard that. You also want to see if there's humps, hills, okay? This is where the rise from 10% to 90%, okay? This should be less than 150 milliseconds, okay? And a rise time of more than 150 milliseconds is often associated with a submaximal effort, and it's characterized by that rounded flow volume curve, and this should be discarded. Discard these submaximal efforts. That's why I really like overlaying the flow volume. And this was just a publication where they took healthy volunteers and they dropped an esophageal balloon in there to measure the pleural pressure, which was their identity for effort. And they found, they documented that the more effort there is, the lower the FEV1. And we do always want to take the highest FEV1, but it's supposed to be forced. Okay, so there's the contradiction there. You want the highest FEV1, and if you force it, there's an inverse relationship. Okay, so we recommend that those values are discarded, even though very often they have a higher FEV1. But if they come from not forced, you don't generate the airway resistance, and so you can have a higher FEV1, but they want it to be forced. So we recommend discarding these submaximal efforts. Back again, talking about the acceptability, the back extrapolation of that second thing, okay? There must be no evidence of a faulty zero flow. This is required for both acceptability and usability for both FEV1 and FVC. Maneuvers that are conducted with this can either underestimate or overestimate, and they should not be used. We do not want to cough. There must be no cough in the first second if you want an acceptable or usable FEV1, but that's not required for FVC, okay? Cough during the first second of the maneuver can affect the FEV1, and that's why it would not be acceptable or usable. But the FVC might still be acceptable. Okay, so here we have a volume time graph, which is the easiest way to see coughs. This is a flow volume graph where it's easier to see the coughs. This is a volume time graph where it's a little bit more challenging. Once you have these changes of direction, you suspect a cough, you want to measure to find out where is your FEV1. Many softwares will give you a spike at that point. And if your cough is before your FEV1, that's an unacceptable FEV1 and you would not use it. If your cough is after the FEV1, you can still use it, okay? Sometimes patients just can't get there. These are our spikes the straight lines here are our spikes. And this patient just wasn't able to get without a cough. So you report in your comment section, patient unable to perform an acceptable maneuver, best result given or no results given. Okay. And the deal breaker, of course, is still glottic closure. You do not want glottic closure in the first second in order to have that for both FEV1 and FVC. Children is not a second, it's a 0.75 seconds. You can see glottic closure on the volume time graph if it goes flat without coming to a plateau gradually, or it's a little easier to see on the flow volume where it suddenly drops down. All right. Within maneuver acceptability for end of forced exhalation, it does want to continue from the FEV1 all the way out to either a plateau, time, or repeatability. And it has to get back to that maximal expiratory level. Oh, glottic closure still stuck in there. All right. Within maneuver acceptability, here is directly from the guidelines, the algorithm. Did you achieve the plateau, defined as less than 25 mLs and held for at least a second? Yes, I did. Forced vital capacity meets end of forced expiration acceptability criteria. No, I didn't reach a plateau. Well, if you didn't reach a plateau, did you achieve 15 seconds of expiratory time? Yes, I did. Okay, you're acceptable. No, we didn't quite make it to 15 seconds. Well, the FVC is within repeatability tolerance, then it would also be acceptable. If it did not get a plateau, it did not get out to 15 seconds, and it's not repeatable, it might still be usable. All right, 1 of 3. Okay. All right, this is an acceptable graph. It does get all the way out to the 15 seconds. All right. This one cut off, and it is not an acceptable. No, I'm sorry, it is an acceptable because they got everything out. It comes gently down and it doesn't drop down. All right. So within maneuver acceptability, obstructed mouthpiece or spirometer. If they are biting down on the mouthpiece, if their dentures or tongue or anything else is blocking things, then you would have an issue with the blockage of that. You would see it here most easily on your flow volume loop. Okay, that would not be acceptable, but may be usable. And of course, leaks. Okay, you don't want to have leaks. All right, so FIVC starts from that maximal expiratory level, goes back to the maximal inspiratory level, and you want to make sure that it's the maximum volume. You don't want it too big, and you don't want it too small. All right. So we've talked about the spirometry procedure, acceptability, usability, and repeatability. Okay. The repeatability is, are the FVC values the same? Okay, so for anyone over the age of 6 years, they have to be within 0.15 liters or 150 mLs. And this applies to both the forced vital capacity as well as to the FEV1. If they're less than or equal to 6 years, the numbers are 0.1 liters or 10% of the highest value, whichever is greater. So you combine acceptability and repeatability. Did you perform the maneuver? Okay. Within maneuver criteria met? Did you meet that within maneuver? Yes. Did you achieve 3 acceptable FEV1s and 3 acceptable FVC maneuvers? And between maneuver criteria are met, are they within 150 for those over 6 years old? Then we determine the largest FVC and report that from any maneuver. We report the largest FEV1 from any maneuver. They do not need to be from the same maneuver. And all the other data is going to come from the single maneuver that has the largest sum of FVC and FEV1. And it may be that the FVC comes from maneuver number 2 and FEV1 comes from maneuver number 4, and the highest sum is from maneuver number 5. Okay. All right. Session grading. We grade the session, the whole testing experience, based on these 4 maximums again. You get a grade A if you have 3 or more acceptables, and the top 2 FVC and the top 2 FEV1s are within 150 mLs for adults or within 100 mLs for those 6 and under. If you didn't quite get 3 acceptables, you just got 2 acceptables, but you're still within that 150, you get a grade of B. You'll get a grade of C if you have 2 or more acceptables, but you didn't quite get them in within 150 mLs, you got them within 200 mLs. Grade of D is 2 or more acceptable from 250 ml gradient differences. So this is how the whole session gets its grade. And then you're going to put in comments. This is very blurry. My apologies for that. You're going to put comments in related to the patient effort and whether or not they met ATS criteria for various things, and so on. All right. So now we're going to look at troubleshooting and coaching. The systems are supposed to give the operator warnings if there are issues going on. A hesitant start should trigger a warning with too big of that, and you need to tell the patient, blast that immediately when you're completely full. No hesitation over 2 seconds. Okay. Rise time, blast faster. Okay. This one is not acceptable because the start was not fast enough. So you want them to blow out immediately and faster. You want maximal effort, nothing blocking. And if there's no plateau, the system should let you know, and you can still get to acceptability if you can carry it out for at least 15 seconds. Keep going, keep going, keep going until completely empty. The system should warn you if there's a hesitation at maximum volume. You want that less than 2 seconds. So you say blast out completely when full. Don't wait. No hang time up there. The system should let you know when there's too much variability in the volume. You want to have them take the deepest breath possible and keep going till completely empty. Ideally, repeated efforts should have similar volumes, not so far apart. And you do want the FIVC to be like the FVCC. You don't want it to be submaximal there. All right. Slow filling. No glottic closure. If there's coughing, sometimes a sip of water will help before the next effort. All right. The CDC and NIOSH got together to do a publication, and it's to help get valid spirometry results every time. The valid test has 3 or more good curves, and they have a repeatability between the FEC and the FEV1. This is the whole poster. We're going to take a very quick look at each one of these. But before we go there, make sure that you've thought about all the different things that could give poor performance. Is the patient performing poorly because of pain or stress incontinence or not understanding or getting tired out? Keep in touch with your patient. Ask your patient how they're doing. All right. What's the problem here? We have a slow climb, which gives us a rounded or flat peak. This is a poor initial blast. What instructions do you give the patient for the next attempt? Coaching, blast out the air harder. What's going on here? Slow takeoff. The peak is shifted to the right, away from the y-axis. This is hesitation or slow start or large extrapolated volume. How do you coach to correct this error? First, you delete the curve and you coach them, blast faster. This has curves, dips. What's happening here? Cough in the first second. Try giving them a drink. Sometimes water will help. Gaps between the different ones in the overlay. Incomplete inhalation before they blasted. Take a deeper breath before you blast. Make sure you're full. All right. This quit and never flattened. Okay. No plateau before 15 seconds. Keep blowing, keep blowing, keep blowing until I tell you to stop. Okay. Variety in the different curves. Inconsistent effort. One continuous blast and keep blowing. All right, curving wobbles is partially blocked mouthpiece. Make sure that their tongue is not there, their dentures are not moving around. Make sure that they're not biting on the mouthpiece, that it has a slight occlusion. Position that mouthpiece well between the teeth and on top of the tongue and secure the dentures. Okay, no glottic closures, quitting early. Okay. You can tell them to relax. They need to make sure that there's a forceful blast that's all the way past that FEV1, but they can relax, particularly if they're forcing so hard that they're turning red and their eyes are bulging and their neck veins are bulging. They can back off the pressure, but keep blowing until everything's gone. Curve drops or moves backwards is a leak. Check your equipment, check your nose clip, check your mouthpiece. Make sure that there's no leaks. Curving down, these are kind of hard to see. This is a negative zero flow error. Make sure that your flow tube is in the right position. It's upright and level to the floor. The positive flow error, coaching is to hold the sensor upright during the test. Extra breaths should not be happening. Okay, use the nose clips and the lips and make sure they're tightly sealed, and make sure that your patient understands the instructions and follows your instructions. All right, spirometry resources for further information. American Lung Association has a spirometry training, so does the AARC, and so does the CDC. And any questions?